Hello everyone, Randy Moore here with MSK Masters again. Just a quick little thing to share with you. This is a not common, but something that you do encounter. I thought it was important just to share with people. This is an evaluation of the supraspinatus when you're doing your rotator cuff evaluations, and the insertion of the supraspinatus on the greater tuberosity has a 1 centimeter wide insertion footprint on the greater tuberosity, as you can see here highlighted in green on this anatomic diagram. The arrows indicate, they're from my textbook, but the arrows indicate that the patient is in the modified Kraft position to expose and stress the supraspinatus tendon for the ultrasound examination. And so there you can see on the graphic there, it's a long axis, obliquely long axis probe placement on the greater tuberosity. It is a 1 centimeter wide avascular area, which makes it more prone to have problems like this. So just really quickly here, going to show you a normal image, and then we'll move on to the curious finding here. So here you see a really beautiful hyperechoic fibrous architecture of the supraspinatus tendon inserting onto the greater tuberosity, a nice linear anechoic uniform thickness tendon footprint, anatomic neck on the humerus, humeral head, and then the anechoic interface here, that becomes hyaline cartilage. So don't confuse that footprint with hyaline cartilage. But this is really just a very pristine looking insertion of the supraspinatus on the greater tuberosity. Now here's the other finding here is the abnormal finding. And so here you see another long axis view of supraspinatus in the long axis view, and we're basically have the probe situated in kind of the beam angling to the posterior half of the supraspinatus insertion on the greater tuberosity. You can see the hypoechoic tendinotic tendon that we see here, areas of more advanced tendinosis here, but not necessarily fiber failure and retraction, a little bit of fluid in the subdeltoid bursae here. So again, this is the posterior half of that 1 centimeter wide tendon insertion. If you look at the image below, this is the anterior portion of that 1 centimeter wide insertion on the greater tuberosity. And all I had to do was just like translate the probe, just maybe half a probe width anteriorly, and I picked up on this finding. And if I wouldn't have done it, that would have, that would have been, something. Oh well, it's, advanced tendinosis, no really significant tears, could be addressed with regenerative medicine therapies for sure. But then with just that slight redirection of the transducer, we pick up on this very notable finding. We actually have a little bit of a hematoma where the tendon where it bled after the rupture, beginning to retract back to the left or proximally. So moral of the story here is that when you do these long axis view of the supraspinatus, just slightly sweep the transducer P to A to make sure you get the full view of the full width of that tendon insertion, and then you don't want to miss things like this. And this patient is still a candidate for the regenerative medicine therapy, because the dynamic testing still showed some fiber threads that were going all the way over here to the insertion. And I've done this many times where I'll go ahead and just inject into that area where we see almost like a complete void of the tendon, and it does remodel, it regenerates. So don't underestimate the power of specific placement. I cannot overemphasize that. Specificity of placement in regenerative medicine cannot be overemphasized. And this is all part of the training and protocols that we teach you with MSK Masters relative to the imaging. And then also the next step is to do ultrasound guided injections in regenerative medicine. So thank you again for your time, and stay tuned for more and more of these videos out here to try to share as much information as we can. Thank you again.